Assalamu alaikum. Good afternoon, everybody. I will be talking about role of immunotherapy in HCC. So this is William Coley. This is a guy who is now receiving a lot of appreciation. 100 years since he started to think about the role of immunotherapy in treating cancer. So it's more than, it was in 1891 when he started to use an unusual approach at that time, when he inject people with incurable cancer with bacteria to induce the immune response. And he approved at that time there is some response. So the interesting thing about him, it's not only about his novel discovery, but he was an orthopedic surgeon. So it's really interesting. So immunotherapy, cancer drug, hailed as a game changer, and as you know, all of us as oncologists, we agree that really immunotherapy is a real game changer in our era. In terms of mechanism of action, side effect, the way how we...
Can you remove the other one? Yeah, the one making the
Which one?
noise. Turn it off, the one who makes the noise. It's not, just hold it, doctor.
Okay.
Thank you.
Okay, so again, as I was saying, the immunotherapy is a game changer in a lot of aspects in our oncology care nowadays, in terms of understanding the mechanism of action of drugs, dealing with side effect, assessing the response, and of course, the most important thing, the durable response that we see in different aspects of different solid cancer. In addition to that, in terms of side effect, I think we used to have the classical teaching of oncological emergency that includes spinal cord compression, febrile neutropenia. But I think with immunotherapy, we start as oncologists to know more about more serious side effects like fulminant hepatitis that can happen, colitis, as a new oncological emergency that we should be aware of. So in terms of HCC, when we want to talk about the role of immunotherapy, as you can see in this left arm here, there is a lot of gene mutation that can be seen in HCC. Unfortunately, there is no targetable agent. And if you compare it to the other malignancy and other solid organ, there is some form of mutation that we have already established targeted treatment, or at least that we know they are responding to some sort of therapy. So this is one of the challenges, that we don't have a driver mutation in patient with HCC. And as Dr. Ashwag went over the systemic approach in patient with HCC, again, for us as a medical oncologist, and even when we talk to the patient, the benefit is modest, and it's not really robust to encourage us as a medical oncologist to use it in a patient who have two problems. They have a liver disease, and on top of that, they have a cancer. So it's really a challenging situation. So moving forward, the role of immunotherapy or the idea of immune response in patients with HCC, it's not new. So this was a publication in 1998. So they looked for patients with resected HCC, and they looked to the CD8 T cell infiltration, and they came up with a score for low or high infiltration of T cell. And as you can see, the recurrence rate with those with high infiltration with T cell was less compared to those with normal infiltration with T cell. This was duplicated in another publication when they looked to the interior part of the tumor and the margin of the tumor, and it showed consistently the same result. And again, the role of immunotherapy is not new in HCC. So this publication was in 1989, and they looked to the role of alpha interferon in comparison to doxorubicin. We know that HCC is a chemo-resistant, but this was the treatment that they used at some point. And because of toxicity, another 2 trials done, and this approach was not adapted. So moving forward, over many years, different approach in patients with HCC has been implemented, or at least studied, including immune checkpoint inhibitor, tumor ablation, oncolytic virus, and there are ongoing trials on different of this aspect, but I'm going to focus about immune checkpoint inhibitor. So this is T cell. It's regulated by activating signal and inhibitory signal. And in order to stimulate the T cell to do its job, either you have to inhibit the inhibitory signal or boost the activating signal. So CTLA4 and PD-1, it's what we know now, and what we already understand a lot about it in terms of treatment and clinical beneficial. So phase 2 trial, this is actually one of the earliest signs about the role of immunotherapy in patients with HCC. So they included only patients with chronic hepatitis. It's a small number of patients. They included about 40% of patients, they were child B, and the patient previously treated with sorafenib or systemic chemotherapy, and they have a measurable tumor. And they gave them a Nivolumab in a dose of 15 milligram per kg every 90 days. So this is one of the interesting findings. The overall response rate was 17.6%. But the other interesting finding, that the viral load of HCC also decreased during the course of the treatment, which was correlated with the response to the treatment. Again, this is the disease control rate here is 76. So most of the patients, they achieve stable disease. 3 develop progressive partial response, and 4 develop progressive disease. So this is opening the gate for a bigger trial, and Nivolumab was studied in advanced hepatocellular carcinoma. This was the CheckMate 040. It was an open-label, non-comparative study. It's phase 1, then they went with the dose expansion to have a phase 2 study. So they included patients with viral hepatitis, and they included patients with HCV infected and hepatitis B infected. And as you can see here, they went with the dose up to 10 milligram in patients without viral hepatitis, and they were careful about the dose with those with HCV and hepatitis B virus. And after that, they expand the study, and they included 214 patients, and they classified them based on their sorafenib untreated or intolerant sorafenib progressor, and based on etiology of their tumor. This is the inclusion criteria for the patient, and as you can see here, most of the patients, they have good child score, less than 7. And when they went to the dose expansion phase, they limited this to less than 6. So we can see it's only child A patient. And they have to get effective antiviral therapy required in HBV cohort. Their primary endpoint, as with any phase 1 study, to assess the safety and tolerability. And in the expansion phase, they look for the overall response rate. So this is the baseline characteristic of the patient. All patients were 262. Most of the patients, they received some form of systemic therapy, mainly sorafenib. 76% of them, they received treatment. About 70% receive sorafenib. And as you can see here, few number of patients, they were a child score more than 6. So this is just to summarize the adverse effect, the safety profile of Nivolumab in patients with HCC, because it was a major concern in someone with abnormal liver function already. Some of them, they have hepatitis B. So actually, the safety profile was comparable with other safety profile of Nivolumab in other solid malignancy. However, there was some slight elevation in the AST and ALT, but there is no actually major difference. So now, this is the, in terms of efficacy, as you can see here, this is the objective response, 20% of all patients. Actually, 3 patients achieve complete response with the treatment. Most of the rate of disease control was about, where is it? The rate of disease control was 64%. So most of the patients, they achieve disease control rate. And if you look here to the overall survival of 6 months and 9 months, 83% of patients were alive in 6 months, and 74% at 9 months. And of course, we are talking about second-line HCC patient, and these are really encouraging. Moving forward, this is the time to response and the duration of response based on etiology. And I think it's comparable between the different arms in sorafenib naive, sorafenib experienced, and sorafenib experienced in the expansion phase. So the duration of response range from 17 to 19 months. And as you can see here, based on etiology, most of patients, they achieve disease control rate. And some of them, they have a partial response, which was not really significant between the etiology, hepatitis B and C. So this is the what they call spider plots. So many of the lines, as you can see here, depend on the responder. But what I want to just to focus here that for those who achieve response, as you can see here, the response is durable, which is something unique to the immunotherapy in general. And when you look here to up to 18 months or 15 months in patient with HCC in a second line setting, actually it's something robust. Now, this is more about the etiology of an affected and sorafenib progressor or sorafenib intolerant patient. And again, it's just to show you the duration of or the duration of response in targeted lesion, that it was last, and if it's happened, it's durable. Again, it's the same, just it's all going into detail with about hepatitis C virus or hepatitis B virus. I think all of them, they receive the benefit regardless of etiology. Now, the overall survival, as you can see here, in the dose expansion arm, it was 13 months. And in the dose escalation, it was 15 months. And this is really a significant outcome on patient, and I don't think any of the study that Dr. Ashwag presented this morning reached to this number. The good thing about PD-L1 expression, it's very good outcome for us as an oncologist because we diagnose HCC mainly radiologically, and if it was PD-L1 response dependent, that means that we have to do biopsies for our patient. Now, regardless of the PD-L1 expression, the response was the same regardless of PD-L1 expression. This is just an update about the survival, which show consistent result on the median overall survival in both the sorafenib experienced and sorafenib naive patients. So mainly based on this study, the FDA approved the Nivolumab at a dose of 240 milligram every 2 weeks in a patient progressed on sorafenib as a second line in patient with HCC. And based on this finding as well, the phase 3 study in the first line setting is undergoing, and hopefully this will change the paradigm of treating the population with HCC from tyrosine kinase inhibitor with modest benefit to the era of immunotherapy. Now, the second study was presented recently in ASCO 2018. It looked for pembrolizumab in patients with advanced hepatocellular carcinoma and previously treated patient with sorafenib. It's a phase 2 study. They included patient with pathological confirmation HCC. They have a good performance status, and the predicted life expectancy was 3 months. So the comparison was best supportive care. And if you can see here, they included 104 patients. And again, consistent with the result of Nivolumab, the disease control rate was 61%. And if you go here, you will see that one patient were able to achieve complete response. 34 patients developed progressive disease, and a good number of patients achieve stable disease. This is to show you the treatment exposure and response duration. Usually you will see the response within 8 weeks of treatment. And the arrows, small arrows here that you see, that it's indicating ongoing treatment. And we are talking here about 36 weeks and here about 48 weeks. So 17 patients responded, 16.3 the overall response rate. The median time to response was 2.1 months. And the response duration more than 6 months is 94%. And this is really another good result. Again, I'm showing you it was consistent with the Nivolumab study, the response in hepatitis B or hepatitis C virus or uninfected individual, they all respond and benefit from the treatment. This is the early analysis of the progression-free and overall survival. We just went over in a few minutes. Now, when we look to the management of patients with HCC, there are different other options, different thought and theory about the role of local treatment in addition to immunotherapy. So if you if there is some theory that you look to the acute immunological response that happen with ablation or embolization, with the theory that it induces hypoxia and stimulate the immune response. And if you give them immunotherapy on top of that, this will increase the chance of response. So based on this theory, there are ongoing trials as well that look for transarterial chemoembolization in addition to Nivolumab. And still ongoing study, we don't have data about it, but it will be also an interesting thing to know. By this I conclude. Thank you very much.